files. So I'm going to use this file from AGS. Can share the screen with you guys. So I'm going to use this file from AGS. Can share the slides. So I'm going to show you one of the files. This is not the teaching slides, but basically the Gait statements in all the adults can be presented by different approach or different styles. So we can say, let's say, the diagnosis is unsteady gait in general, and the causes might be different. Starting with neurological causes, the most common neurological condition that we face or see in all the adults is like stroke. So patients with stroke might present with one side weakness, and this might be present like a gait that is round or have a circle of the leg. We will see them in the coming slides. I think we have some. But other causes of the gait abnormality include sensory problems. For example, patients with diabetes might have problems or peripheral nervous diseases or peripheral neuropathy might have some problem presenting with gait abnormality. Any problems with the nervous system, vestibular system, cerebellar, and the basal ganglia also can affect how we walk. So if we look at some of the tracts that might be affected, the cortical spinal tract, for example, this will show as a spastic gait. This video, we will show you the hemiplegic or spastic gait. So I'm gonna try to open the link and
need to start.
Can you see the video? Yes.
We can't see, Doctor.
This is the position of the hemiparetic gait, with the other side being normal, having normal associative movements. You can actually hear the pattern of the gait as well as we have circumduction with the paretic side. Again, watching upper extremity postured into the decorticate posture, lower extremity is actually circumducted, coming around. The gait that
question about this, or did you listen to the video, or should I just run it and explain it? Any feedback? the gait itself, you can look at the movement of the leg, and it goes like half a circle outside. So the patient will usually pull up the leg using the muscles of the hip, basically, and then try to move the leg to the front, but it's not gonna go straight. So it's gonna go outward all the way and come back to the midline. So it makes a half a circle. And if you look at the toe, the big toe on that leg, this is the one that's almost touching the ground and making that half a circle, if that makes sense. So, and as the video showed, it affects one side, so the upper extremity also will be affected. So there will be a weakness on that side, and that weakness will be demonstrated by flexion of mostly all the joints on that affected. So the upper extremity will be abducted and then rotated and flexed. So every joint will be flexed for what we call baby position or fetal position. Everything is curled or flexed. Any problems with the voice? Someone mentioned the voice.
Yes, the voice is not clear.
Any, is it better now?
Yes,
Yes,
it's way
it's
better,
better
doctor.
now.
Yes, okay.
Yes.
So can any one of you tell me if you saw or you encountered patients with this in your practice or in the street or in your environment where you go to, like hospitals or clinics? Can you share your experience with this gait? Have you seen any patients with this gait?
Yes, I see a patient with abnormal gait, diagnosed as Parkinsonism.
Okay,
Mhm.
so
Shuffling
we
gait.
can move on to the next gait, which is ataxic gait. And usually this is when you have a cerebral disease or condition. I'm gonna share the screen again. Okay, just a second.
Narrowing the station and maintaining balance. So
So I'm gonna start from
the last gait that I'm going to demonstrate is the ataxic gait. In the ataxic gait, the patient has difficulty narrowing the station and maintaining balance. So typically they'll have a wide stance, is trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is a anterior posterior type tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, I then try to walk tandem, then I'm going to have difficulty walking.
So basically, the spastic or this type of gait, ataxic gait, is when you have problem with controlling the movement of the body. Usually, it's an intentional movement when you want to move your arms, your legs, when you want to walk. But with this type of disorder affecting the cerebral lesions, stroke, or other tumor or any other lesions, then the movement will be unintentional. And if it is like the gait is an intentional movement, then there will be like a movement contracting the abnormal movement. Let's say you want to walk straight. Your brain has problem with the cerebellar area. It will inject the abnormal movement, which is tending to lean to the right side. Your brain will try to catch you from falling down while you are walking. So the lesion will cause an unintentional problem or leaning to the right side. The good part of your brain will try to fix that, and it will try to do that faster. So it will compensate, but it will be an overcompensation. So you will feel that person is trying to fall while walking, and then they overshoot to the other side. So they will, the gait will be uneven, as you saw in the video. And to show this or to display this gait obviously for you while you're doing examination, to ask the patient to use their foot one in front of the other. It's called tandem gait. So you ask the person to put the right foot, then the left foot in front of it, then the right in front of it, and so on. So this way you can elicit or display, exaggerate the movement or the gait abnormality. Anyone saw this in your patients or population or in your environment, in clinics or hospitals? Any comments, any questions, any addition?
Yeah, I have seen many cases, doctor, of this ataxic gait, either due to cerebellar cause or sometimes sensory ataxia due to posterior column affection. And the difference is when the patient closes his eyes, if it is the sensory, if it's cerebellar ataxia, the closure of the eye will affect the ataxic gait will remain the same with cerebellar lesion, while with it's caused by sensory ataxia. It appears with closing the eye and disappears when the patient opens his eyes. There's no sound, doctor. You are muted.
Thank you so much for sharing, Dr. Ahmed. This is great input as well. So there are ways to differentiate where the lesion is. This is in neurology is very important to locate. Excellent. Any other comments or any other input?
Yes, I saw patient with type of essential tremor. Last week he has essential tremor started in his hand, then going up to his face and tongue, and then involved the whole body. When I examine him, I find like he has a lot of injury in his face. I asked him, he said this is due to when he shaving, he got injury many times, but he come due to sepsis. I don't know what is the relationship, but this was very interesting.
Excellent. Excellent. Thank you so much for sharing, Dr. Nadia. So anything can affect, let's say there is an infection in the cerebral area, then it may cause, let's say, small abscess or other conditions that may affect that place. And if there is inflammation, then the function will not be the same. Did they do any imaging to that patient, let's say CT or MRI or any? Dr. Nadia?
Yes, we did. He has also non-history of diabetes, and he came with lactic acidosis. His lactic acid was very high. We did for him CBC and complete metabolic panel. We find he has he's on metformin, and I think lactic acid due to metformin. We stopped the metformin, and he give them fourth generation cephalosporin. And I think he's improving when I was follow him. And also he has like second and third metatarsal amputation, I think due to diabetes. He has multiple condition, but we control his sugar and give him antibiotic, and then his condition is stable, and after that we discharge him. But he said he has this type of tremor. I think it is familiar, but it involved all his bodies, starting from both upper limbs and his face and his tongue, and then go down to his both lower limbs. This was very interesting.
Excellent.
Doctor, I think this is essential tremor, which is
Uh-huh.
autosomal dominant.
Yes.
I
Yes,
think
it
this
is
is
autosomal,
essential tremor.
Yes.
but yeah,
Agree with
but it
you.
includes all his bodies, not just
The
in his.
essential tremor, essential can occur in many areas, including hands and head and neck.
Yeah, he has also imbalance when he walk. I feel him like he's imbalance in walking.
Yeah. So, and that's a good thing to share. Thank you to highlight the importance of other conditions, including essential tremors. And sometimes one condition might be elicited or exaggerated or more dominant or more apparent when you have other condition. Let's say you have a stroke in the past and it's resolved or it's improving. But if you have a UTI, then your symptoms will appear more of that stroke. So what we call hemiplegic, with improvement, we call it hemiparesis, where there is a little bit not noticeable, like the weakness will improve, but maybe not 100%, let's say 90%. When the patient has an infection, then the weakness will show up again. So that part of the brain will not be functioning all the time the same level. With any insult, let's say in this case an infection, then the threshold or the weakness will appear again. And I assume this might be the case with other conditions, miracle. In this case, maybe essential tremor when you have some comorbid condition acutely, then the patient may present some exaggerated symptoms.
So you
And
mean that sepsis exaggerated is essential tremor, the infection? Okay.
into the brain, then the brain will focus on the infection and leave that, let's say, whatever problem working on. So basically, if you think about it, like if you have patients in the hospital, you have patients with minor skin problems, you have some nurses taking care of that patient, and all of a sudden a patient comes with heart attack and you want to do CPR, you want to call the code and you want to take the patient to whatever, then all the staff will leave an urgent cases to focus on the urgent cases. And then the skin problem might exaggerate or something like that, if I want to give you an example. All right, excellent. Any questions or any other comments? Any other input from you guys? So the next gait disturbance or abnormality is common. It's the Parkinson or hypokinetic gait. I'm gonna share the screen.
Folks, I want to show you.
Just a second.
Is the gait that is hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again, having difficulty starting and the marche petit pas.
So basically, with the Parkinson or Parkinsonian gait, you will notice again the gait itself, but in the upper extremity or the body shape, you will find the tremor. You will find the body is kind of leaning forward, and then the gait itself is very small steps and very shuffled. So kind of small. The initiation may take some time, and then when you see them starting moving, then they will move with this type of gait. When they turn around, they turn as one piece, as a statue, and then come back. So this is how you differentiate Parkinson disease, for example, the gait from other type of gaits. Have you seen this in some of your patients, guys?
Yes, Dr. Nader, I saw this type of gait in a relative, and for years they have been treating him with as Parkinson patient, but with no improvement. He don't have the whole criteria, just the difficulty initiation, the small steps, and years later, they found that he had normal pressure, hydrocephalus. And and they did the shunt and everything went good afterward. So sometimes I guess they mix and some gaits.
Yes. And his gait is improving after the procedure?
Yes, it's improved, not completely, but way better.
Yeah. Thanks for sharing. And this is also important. Sometimes you can see the patient, diagnose the patient, but sometimes you need to double check your diagnosis, or maybe there is another component, maybe there is another differential diagnosis. So other tools can help you. In this case, maybe if they do the MRI or the CT scan, and maybe it will show the enlargement of the, or whatever. If they do a TAP, they can get the pressure normal, but imaging may show something. So sometimes some of the medications can cause Parkinsonian syndrome or symptoms, and the gait might be due to some reversible causes. So this is one thing you think about when you examine the patient and see there is abnormality. let's say in the gait, then you can differentiate, put them into two buckets or two type differentiate. Is it possible to fix and remove the cause and get the gait back to almost normal or close to normal, or it's gonna continue like that? So there are some conditions where if you figure out the cause and that condition can be treated, let's say with antibiotics or removing the causative or causing medication, then hopefully the brain will go back and the gait will improve to some extent. So in this case, the normal pressure hydrocephalus, then the treatment is a procedure where you put the shunt and then you improve the pressure, and the brain will relax, and then the gait will improve. And if there are other symptoms also, hopefully this will improve as well. Thanks for sharing, Dr. Wissam. Anyone else? Any other aspects or any other input from you guys?
I have seen a case similar to this case with normal pressure hydrocephalus, and the main complaint of this condition was urinary incontinence. The patient came with urinary incontinence. At this time, I couldn't identify the exact type of gait, but she has had abnormal gait with urinary incontinence and some the symptoms of dementia, and was diagnosed later on as normal pressure hydrocephalus. But the gait was difficult. Diagnose the gait at this time was difficult to know the exact type.
Yes. So, and that also highlights sometimes the importance of following the patient and doing investigation along the road, or sometimes you may see the patient at the beginning and then you say, oh, this is, I think this is diagnosis. And if you follow the patient, maybe you will see more symptoms to suggest a different diagnosis or highlight the differential diagnosis and help you get some more investigation and so on. Great. Any other input from you guys, or you want to share any?
Also,
right.
I saw patient with extrapyramidal side effect, I think from antipsychotic medication. He was young, and when he came with like Parkinson feature. He has tremor and steady gait, and he has imbalance. When we take history from him, I find he has increased his dose for antipsychotic. He was on risperidone. We adjust the medicine, and after that, he was improved.
Yes. So thanks for sharing. So this is one of the important thing about antipsychotic. It's one of the important side effects that we need to pay attention to, and there is a way of checking is movement abnormality. There are different types and different part of the body will be affected. The oral movement, the tongue movement, and as mentioned in this case, the gait might be affected. So you want to look at that when you put the patient on this medication, follow and do some serial examination and what we call AIMS score. So AIMS is a form where you have, let's say, 7 items or 7 sections where you will look at the mouth, see if they have any movement, tongue, any movement, and you score that. The normal score is 0. If it's more than 2, let's say 3 or more, then it's most likely the movement because of the medication. In that case, then you remove the medication and see if there is improvement in the condition. Then most likely it's medication. However, if the patient on this medication for a long time, then their abnormal movement, the tongue or the movement of the lips or the gait abnormality may persist even if you stop the medication. And most of the time, we don't want to stop the medication in these cases because of the severity of the disease. So some of the patient may have severe condition where they were tried on different antipsychotic for a long time, and they were controlled with some, and then they have the these side effects. Usually the psychiatrist will try to take the medication off and see, and if they have relapse of the symptoms, then they will continue with antipsychotic, because it's a balancing between the benefit and the risk, which mostly done in most of the geriatric medicine, is to see how we can benefit the patient with the minimum side effect or risk. So if they benefit, they are not causing problems to others, they are not thinking of harming themselves with the medication, then they can live with some abnormal movement, let's say. Okay, thank you for sharing. And Dr. Rim, please go ahead.
Yes, I want to mention that also we have to give attention to Lewy body disease, because sometimes we can confuse them with Parkinson's disease, especially when they consult at a late stage, because usually they don't consult because of dementia, but when they notice gait change, so they come for Parkinson gait. So yeah.
Yes, thank you so much, Dr. Rim, for sharing this important also aspect. And this again comes with long follow-up. So if you see the patient for a long time, or in this case, if the patient has some condition and it progresses, they may develop some symptoms similar to other conditions, as you mentioned. So there are some symptoms might be shared between different conditions, dementia and Parkinson disease. Some patients with Parkinson disease, as they progress in their condition, they may develop dementia, and vice versa. Some patients with dementia may develop some symptoms of Parkinsonian gait or other abnormal movement disorder. Thank you so much for sharing. Anyone else?
Excuse me, doctor, can I add another thing?
Go ahead, yes.
I previously seen a case in the emergency room. It was a case of middle-aged man, and he came with a gait similar to this gait. And when I see him, I thought it is Parkinsonian gait. But when I asked the neurologist who knows the case, he told me that this is a case of severe depression, and he came with what's called the catatonia. And the gait was very similar to Parkinsonian gait, but what I thought was completely wrong, and the patient was catatonic depression.
Okay. Thank you so much for sharing, Dr. Ahmed. Yeah. Anyone else wants to share? We can move on to the next type of gait abnormality, and this might be very common. And I'm going to show you the video. All right, it has a name. I wanted to quiz you, but you can figure it out, and it's written there. So patients who are consuming a lot of alcohol, or in this patient, then you will have the patient with abnormal movement because of the alcohol. So this I'm not sure if it's clear in the video, but they will be moving from side to side. They may be unable to move well, depending on how drunk they are, and they may have some falls. Have you seen any of these patients in your practice or in the environment?
Doctor, you are muted, doctor.
Your mic is off.
Sorry about that. Any comments about or any? If not, we can move on to the next gait. It's the dyskinetic or hyperkinetic or sometimes coloriform gait, where the patient may have lesion in the basal ganglia, caudate nucleus. So I'm going to show you the video.
The hypokinetic gait. We now have the hyperkinetic gait, which we see what we call a choreiform gait or chorea. With this gait, there are not only abnormalities in the gait itself, but associated movements. There can be oral facial dyskinesias in which the patient, which will be having movements of one side or the other side of the face, kind of a grimacing type of a fashion. There can be movements in the upper extremities, and there are fragments of semi-purposeful type of movements or writhing type of movements. And then the legs will also start to go. And so the patient attempts to walk, get the superimposition of the movements, but the patient doesn't actually fall.
Dr. Nadir, the video is not available.
Sorry, I share with you the screen. I need some coffee. Just a second.
As opposed to the hypo.
You can see it, right? Can you see it?
Yes.
Yes,
Yes.
we see now.
We now have the hyperkinetic gait, which we see what we call a choreiform gait or chorea. With this gait, there are not only abnormalities in the gait itself, but associated movements. There can be oral facial dyskinesias in which the patient, which will be having movements of one side or the other side of the face, kind of a grimacing type of a fashion. There can be movements in the upper extremity.
Dr. Nader, the sound went off when you muted yourself.
Opposed to the hypokinetic gait, we now have the hyperkinetic gait, which we see what we call a choreiform gait or chorea. With this gait, there are not only abnormalities in the gait itself, but associated movements. There can be oral facial dyskinesias in which the patient, which will be having movements of one side or the other side of the face, kind of a grimacing type of a fashion. There can be movements in the upper extremities, and there are fragments of semi-purposeful type of movements or writhing type of movements. And then the legs will also start to go. And so the patient attempts to walk, get the superimposition of the movements, but the patient doesn't actually fall because the balance is not affected. Just you have these involuntary movements that are now being superimposed on the gait.
تخيل قوة خارقة.
So this could also affect some of the patients. So have you seen any of this?
Yes, I see this during my house man in Jafar ibn Auf. There is one mother have 5 kids. Unfortunately, the 3 of them have a chorea. I think it is hereditary. And during the round, I think we noticed the smallest one, like 9 months, also starting movement in the foot. And at that time, the boss said this also, the 9 months will be developed the same sibling.
Thanks for sharing.
Welcome.
Yeah. So as Dr. Limia mentioned, chorea runs in families, and sometimes you may have the movement, sometimes they may have tics or even some sounds, some voice or cries. So it may affect the gait, but it's not gonna cause, as they mentioned in the video, falls. It's just for you to look at it, you will see the abnormal unintentional movement of part of the body or the whole body, and then you can assess. And the good news, there are some medications there. Hopefully it helps. So any comments or any inputs? Thank you.
So, Dr. Nader, I have a question regarding this type of chorea. This like Huntington disease, the same one, or there is difference between Huntington disease and this type of abnormal movement, as you mentioned now?
Yeah, I think there are differences between them.
Mhm.
Anyone interested in neurology, they can clarify that.
Yes, I think Huntington, it is because anticipations. It is the first generation maybe in 50 or 60, but the second generation like 27, but not in the children. I think this is not Huntington. It is not start early in the children, but can be start in the elderly. After that, anticipation is second generation, like a 10-year more like that, but it's a different, I think.
Because you said three child with the same condition.
Yes,
So
but the oldest one like 7 years, 5, 3, and the eldest, the smaller one is 9 months. But I didn't think it is, and the father and mother have no any like that in the running family.
Okay.
Thank you so much. And I was highlighting just the gaits in older patients, but in pediatric also there are different conditions that will affect gait. If anyone interested in pediatric, then they can look at that as well. But for now, let's stop here. And any other comments about gait or gait abnormality in older adults?
Sometimes, doctor, muscle weakness, proximal muscle weakness in the area of thighs, like myopathy or severe vitamin deficiency or osteomalacia or so on. They have a gait like what's called waddling gait. I saw this gait in many patients, but not geriatric. But I expect that can be presented in geriatric.
Yeah, you're right. So there are a couple of other causes, and some of them might be fixable, or you can adjust and see if there is improvement, and some you might not. So I didn't touch on all the gait abnormalities. This is just a short list of some of the videos that we have. There is a template where you have the whole topic about gait abnormality in all the adults. We can share that later on. But let me show you this. I'm gonna share it also with you guys in the chat. So this is from Stanford. They show you how to examine the gait, and I think most of you know how to, but if you are here, there are different ways.
With an abnormal gait, and for us to send the patient for...
So different ways of doing it, but in general, you have your preference. So this is one way of doing the gait examination.
Testing or consultation when the diagnosis might be fairly evident in the gait. The most common gait you'll see is the hemiplegic gait. And this is one that you see in hemiplegia, where the arm is typically in this posture and the leg on the affected side is typically somewhat stiff. And they will then have a gait that looks something like this. And the characteristic of the gait is the circumduction of the foot. The fact that the foot is making a circle like that is what makes this gait so characteristic. If the condition is mild, the hand may not be flexed up like that, and the only manifestation might just be a little circumduction, and the hand may not be swinging normally the way the other hand swings. So that is called the hemiplegic gait. It's important to understand why they do what they do. When you cut the pyramidal tract on the left side, you have abnormalities of tone that manifest on the right side. So you develop flexion hypertonia in the upper limb and extensor hypertonia in the lower limb. And that accounts for the leg being like that and the hand being like this. In addition, they develop much more distal weakness than proximal weakness. Their shoulder is strong, the fingers are very weak. The thigh is strong, but the foot is weak, and so they have foot drop. And so the circumduction comes about because A, they have extensor hypertonia, so the leg is stiff. Otherwise, they could just step like this, they could go like this. And B, because they have foot drop, because they have weakness distally, they can't lift up the leg and step like that, so they wind up circumducting. So this is the most common gait we will see around here probably. It's called the hemiplegic gait. Another gait that we would commonly identify is the gait of Parkinson's disease. It's a posture that's characterized by universal flexion. Every joint is flexed, and the patient typically will take very small steps. This is called a festinating gait. The French call it the marche à petits pas, the walk of little steps. And there might also be an associated tremor with the gait. The patient may have a myriad of other abnormalities related to the Parkinson's that we're not going to cover in this session. Another gait that's very helpful to recognize, and it may be one that you're all familiar with from watching police videos and hopefully not from personal experience, is the cerebellar gait. The cerebellar gait is characterized by a broad stand and by a wide staggering quality to it. People will tend to fall towards the side of their illness. So if the illness is in the cerebellar hemisphere on the left, they might fall in that direction. When asked to stand still, their trunk may sway like this, and that is called titubation, and obviously they would have problems with all the other cerebellar tests. One caveat, many people think of the Romberg test as being a test of cerebellar disease. Now, the Romberg test has nothing to do with the cerebellum. The cerebellar patient is already swaying, and it gets a lot worse when you have them close their eyes. But the Romberg test is really a test of proprioception. When you and I are standing like this with our eyes open, we are getting signals from our joints to tell us where we are in space. If, however, you have a problem with proprioception because of your peripheral nerves or posterior columns, then you're relying on your eyes to tell you where you are in space. And therefore, the moment you ask the patient to stand still and close their eyes, the patient begins to sway. And that is a positive Romberg test. It has very little to do with the cerebellum. Talking about proprioception leads me to the other gait related to proprioception. Once again, if you have trouble with your proprioception and cannot feel when your foot has arrived on the floor, you are relying on a lot of visual cues, and especially in the dark, you might develop what's called a stomping or stamping gait, where you tend to walk like this, needing to slam your foot down to get the vibration in your trunk to let you know that your foot has landed. So this gait may be much more prominent in the dark and not as evident in the daytime because they can see where they're going. A gait that we should mention in the context of the hemiplegic gait is the gait that's commonly seen in cerebral palsy. It's a diplegic gait, if you will, with hemiplegia on both sides. And it's a gait that I'm sure you've seen often in children and in adults affected by this from childhood. Typically, the patients have extensor spasm and almost seem to be walking on tiptoe. And although they have some circumduction, they have a lot of adductor spasm that keeps their feet close together. So they tend to be walking on tiptoe. The arm is flexed like this, and the adduction is a prominent feature. In fact, in some parts of the world where children do not get adductor releases, you might actually see a scissors gait, where the leg swings all the way over to the other side. And again, that is another manifestation of the diplegic gait. I want to talk about a gait that happens in people with myopathy. And this is a gait where the patient develops a waddle. And in order to understand this gait, you have to do a couple of things with me, if you don't mind. Put your hands on your hip, if you would, and appreciate that when you take a step to step forward, the hip on the side where you are stepping forward, that hip actually moves up. It moves up, and it's a function of having very strong pelvic girdle muscles that allow you to do that. If you have a myopathy, when you lift your leg up to take a step, because you can't hold your pelvis up and stabilize it, there's a tendency for the hip to fall on that side and for you to fall over. And to compensate for that, you lean your trunk this way. So you develop a waddling kind of gait, compensating for the fact that your pelvic muscles aren't strong. You get a waddling kind of gait, leaning away from the side where you have the weakness. In a sense, it's a manifestation also of the Trendelenburg sign. The Trendelenburg sign says that when you lift the hip on the affected side, the pelvis sags down, and it's a suggestion that you have weakness in the pelvic stabilizing muscles. Another gait that we'll discuss is the neuropathic gait. If you have a peripheral neuropathy and you have foot drop, then typically you have to have a high stepping gait. Otherwise, you will trip on your foot and fall forward. So patients with neuropathy, especially if it's bilateral, will have a gait like this, which is nicely also called the equine gait or the stepping or steppage gait. And the reason they do this is they can't step forward without tripping on their foot because they can't really dorsiflex their foot because of weakness. So the foot is weak. And so to overcome that weakness, they have to lift it up like so. The coriform gait does not, in my mind, strictly constitute a gait. These patients are already exhibiting writhing movements, involuntary movements when seated, and when they walk, they can have the most bizarre sorts of gaits. And I don't think it's fair to call it a gait because really the involuntary movement is manifest in pretty much everything they do. I would offer as a caveat that All our hospitals have long corridors, great opportunities to watch patients walking towards you, away from you. And I encourage you to make a habit of studying gaits as people come and go and realize what a miracle it is for people to have a normal gait and how easily it is rendered abnormal by disease.
Any comments on this or any other questions or input from you guys?
Dr. Nader, this video is so much informative. Thank you so much for sharing it. We learn a lot from it.
Okay. Thanks.
And
I
I also,
much
sorry.
for it was very informative, as Dr. Wissam said. I also had a very tough time studying this topic for step 1, step 2, and during my neurology rotation. But this presentation with the videos and everyone who shared real life patient stories, I think it made it much more easier. So thank you so much, Dr. Nader, and everyone who shared their stories.
Thank you. And thank you, everyone. Yeah, and the video from Stanford, I think if you go to that, they have linked other videos and they have very good, this doctor explained very different things in neurology if you are interested in. So the basic of the exams and then the abnormalities as mentioned in this video, for example. So if you want to refresh or if you want to know how they do it here in the US, if there are some differences, then you can learn from them how to do it the way they teach it here. Thank you so much for your comments. Any other comments or any other input from you guys?
Dr. Nader, I just want to mention, in the case of my relative, I just mentioned about normal pressure hydrocephalus. I think maybe the reason they didn't or couldn't diagnose him early, maybe because in the beginning the pressure was small and the picture is not complete. So that's why they mixed it with Parkinson's disease. And then later on, when he developed the urinary incontinence and other symptoms, they did, more investigation. And it was long time ago. I'm not sure if they did any imaging or not, but, this story stick in my mind. That's all. Thank you.
Thank you so much for sharing. Yeah. So again, as I mentioned, sometimes the presentation might be one piece at a time. So if you do a long serial examination and follow up, then these pieces will add up. Then you notice more and more and more. And sometimes you may question your first diagnosis and see if you made wrong or similar close diagnosis and maybe you didn't reach the right one. So this is just put it at the back of your mind that question yourself if maybe it's not clear from the start, or maybe it's mimicking something, and down the road it will show up the actual disease. For example, in multiple sclerosis, they may present with some symptoms. You cannot diagnose that as multiple sclerosis with one symptom. You need at least 2 different lesions affecting the part of the nervous system. And the difference will be in either locations. Let's say you have eye problem and then weakness of the right leg and timing, the duration, or so it will affect the leg first and then the eye second. So there are some criteria for you to differentiate or to diagnose MS, for example. So if the patient presents with eye problem from the start, you may give a diagnosis. And if you follow the patient and then they have another symptoms, then you will say, oh, I think it's MS. So then my first diagnosis is not the right one or something like that. Sometimes with imaging, this criteria has been changed a lot. So I'm not sure what's the recent one. 10 years ago, they were talking about using imaging to just focus on the criteria instead of waiting until the patient has the second symptoms, if that makes sense. And that to improve the condition as well as to improve or prevent further symptoms, if that makes sense, if that makes sense. Go ahead. Dr. Wissam, I think you wanted to mention something.
And also, I want to add, if some patient comes with gait abnormalities, we have to put in our mind first the reversible cause of gait abnormalities, such as we can do investigation, such as vitamin B12 deficiency, hypothyroidism, and any sexual transmitted infections such as syphilis and peripheral neuropathy due to diabetes or HIV. You have to put other causes of gait imbalance in our mind.
Excellent. Thank you so much for sharing, Dr. Nadir. Anyone else wants to share their input or thoughts? So in the chat, Dr. Limia was asking if someone can add her to the big WhatsApp group. If one of you can share the link for the WhatsApp group or communicate with her so that she can join you in the big WhatsApp group, please. And thank you. So if we cover most of the gait abnormality, if there's no more comments or questions or input from you guys, I want to touch base also on how we can prevent people with abnormalities like the conditions that we mentioned from falling, because basically we want them to keep moving. I encourage all my patients to continue moving as long as they can when they are older. So the problem with gaits, the risk of falling increase when they have abnormalities in their gaits. So also there is another fellow, Dr. Halley, wants to be added to the WhatsApp group, please, if you don't mind. That would be great. So in the WhatsApp, if someone can take care of adding the new fellows to the group, the big group, that would be great. So how can we improve or prevent someone with gait abnormality from falling? What can you do? Any one of you can help me?
I think apart from checking the environment around these people, like the furniture, the lighting, I think you should start with the patient himself. Because those patients sometimes also have some vision problems, some hearing problem. So starting with assessing the vision and hearing of those people would be the right thing to do. And then check their environment, their house, and their ability to function alone. So start with the house, with the furniture, with the carpets sometimes, and the areas surrounding them, and then make sure that the environment is safe for them and having someone around to help them and assist them with their daily living.
Excellent, excellent. Yes, so it's important to look at the patient, but also look at the environment. Excellent. What tools can we give them if they are able to use some of the tools or devices that's out there?
Go up test or go up
What's that? Sorry, go ahead, Nadia.
go test, or I think is we assess first of all we have to assess his movement when he come any patient. I think after 65 years old we have to do risk of falls by do the test of go up test to see if he has any abnormalities in his balance or abnormal movement. I think it's like routine testing to do for any patient after 65 to assess the risk of fall.
Excellent. So this one test is done. You can do it in the office, for example. I'm gonna show you that in a clip here. Get up and go, or
The time.
it's called timed up and go test. So I'm gonna share the screen with you guys. Just a second.
Stand up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
So this can be done, as Dr. Nadia mentioned, for older patients. Usually there is a annual evaluation or annual visit health test or comprehensive evaluation for older patients done annually. So this one part of it is you test the gait, and you can test the get up and go test to see the risk of falling and minimize, as mentioned before. Look at the patient if they need eyeglasses, hearing, and if they want to get home evaluation, lighting, carpet, and so on. One thing you can look at also their shoes. In the upper part of the US, for example, snow will be a high risk for like sliding on the ice. So risk of going down with smooth shoes is a problem. It's a problem that can be identified. So look at the shoes and educate the patient. So these are some of the highlights that I want to show or I want to share with you. One thing I want to add is the last part is the assisted devices. In the last video, it was mentioned you need to record how long it took that patient to get up, go all the way, come back and sit down. If it's more than 12 seconds or roughly more than 15, 20 seconds, then definitely that patient is at high risk. And you need to document if they were using a cane or a walker to help them when they move. So my highlighted or the point that I want to share is these patients, you can also evaluate them for assisted device. Let's say they have hemiplegia, they have abnormal gait because of that, then you need to give them hemiplegia cane or walker. Let's see if I can get that. So I'm going to share with you this one. So this type of cane or a walker that they can use when they're walking. So there are different ways of using other supportive devices. The physical therapy may help identify which device that can be used for which condition and so on. So just to minimize the risk of falling. Any comments from you guys or any inputs?
I think, doctor, we also must revise the medication and try to decrease the medications that cause dizziness, sedation, or systemic hypotension.
Yes, absolutely. Thanks for sharing this point. So, yeah, with every visit, you want to make sure you look at the medication and minimize any side effects. Some of the medications in older adults, they may increase their falling and risk of fall. So you want to assess for the benefit and the risk and see which one is beneficial for the patient to continue with the medication and minimize the risk, or stop the medication and see if the patient can be treated with something less risky. Excellent. Thank you so much for sharing. Any other input from you guys? So in the chat, there is a link for excuse me, joining the big WhatsApp group. If you want to join that group, please click on that link and join the group. So any other comments or updates about your projects or ideas? A few weeks ago, we talked about AI and how to generate or make mobile applications. So if you are interested, you can also look at the videos before. Some of you shared their progress in this area last week and the week before, so I appreciate that.
Dr. Nadir, if you remember, I started the case-based learning series, and you recommended that I expanded to have more fellows join in different interest groups like neurology, family medicine, and I did that. So I currently have 80 groups with a total of, I think, almost 30 members right now in different interest groups, and we've prepared a presentation. And we have Dr. Noura that she's ready to present today if we have time. I've added this to the agenda, I think.
Yes. All right. Why don't we do that then?
Thank you so much.
Available, if she is available.
Yeah, if Dr. Noura is here.
Hello. Yes, I'm here.
Yes. So Dr. Noura, please go ahead when you're ready.
Okay. Just let me share my screen.
Yeah, in the meantime, I just want to say if anyone wants to join this initiative, we'll be more than happy to add you guys to the group. Yeah, just contact me and I'll add you to your area of interest so that we have different groups and different specialties.
Thank you so much for doing that. I appreciate it.
Okay. Hello, everyone. Is my screen visible to you guys?
Yes.
Okay. So hi, everyone. My name is Noura Mahmoud. Today, I'll be presenting a case as part of our base case learning series in gastrointestinal medicine, titled as A Tale of Two Bowels. This case follows a patient whose initial diagnosis is later challenged by further investigations, highlighting how similar symptoms can point to very different underlying conditions. As we go through the case, we will discuss differentials, key investigations, and management strategies, with a focus on clinical reasoning and avoiding diagnostic bias. Now, before we start, this session is aimed to be interactive, so please feel free to open your mic and share your thoughts and answers, or you can write them in the chat box. Okay, so our patient for today is Miss Sarah, a 32 years old female presented to the clinic with a 6-month history of abdominal pain, bloating, and altered bowel habits. Initially, she felt a crampy abdominal pain, often relieved by defecation. She describes alternating episodes of diarrhea and constipation. Her symptoms are worse during periods of stress. She's tried over-the-counter medication with minimal relief, and she did not report any rectal bleeding, weight loss, fever, or nocturnal symptoms. In her past medical history, she complains of she's diagnosed with generalized anxiety disorder, for which she's not taking any medication. She works as a marketing executive, non-smoker, and drinks occasionally. She denies a family history of colon cancer or IBD, but stated that her mother always complains of a nervous stomach. Now, on examination, the patient is vitally stable, appears well, not in acute distress. Her abdomen is soft, non-tender to palpate, no organomegaly, and normal bowel sounds. The rectum is of normal tone and no palpable masses. So, for our first question here, does anyone have an idea about the red flag symptoms that we should look into when encountering such a case?
Hello.
Yeah, hi.
Hi, this is Sana. I think we have to ask, as the question mentioned, about the weight loss, and she don't have this, and also about the family history of colorectal cancer or any colon cancer, and also the Miss Sarah don't have this. And also the inflammatory bowel disease, and she don't have these. These the top 3 red flags I remember right now.
Yes, exactly like Dr. Sana mentioned. So any patient with abdominal pain and bloating or altered bowel habits, we should be aware of symptoms like weight loss, fever, rectal bleeding, anemia, family history of IBD and colon cancer, as they may indicate serious underlying condition. And as we can see, in Sarah's case, none of these symptoms are present. Now, moving to the next question, based on this brief history, what's the initial differential diagnosis?
Irritable bowel syndrome.
Yes. Another differentials?
Dyspepsia.
All right.
Inflammatory bowel disease.
Okay. Anyone else? All right, so at the top list, we will consider irritable bowel syndrome, giving her cyclic symptoms, stress relation, relief to defecation, and the absence of red flags. We could also consider inflammatory bowel disease, but less likely without the red flags. Celiac disease is a possibility, but it presents with less prominent bloating and abdominal pain. Also, lactose intolerance and food intolerance could contribute to symptoms, but they're unlikely to explain the full picture of alternating bowel habits. Small intestinal bacterial overgrowth can mimic IBS, so it's still a possibility. And lastly, anxiety or stress-related GI symptoms can be one of the differentials. Now, given the differentials, what initial investigation would you order to start narrowing down the possibilities? Because these are a lot of differential diagnoses, so what test do we need to do?
CBC.
Yes.
Blood count.
Yeah.
Urine analysis.
CBC to check for what? Exactly.
CBC to check for total white blood cell count. Maybe she has inflammation or infection. And also anemia, if she has anemia.
Yes, which is common in inflammatory bowel disease, the anemia. Yeah. What other tests?
Can we also check for fecal occult blood test?
Yes. And
I
while
will
checking
ask
for
simple stool analysis.
Yes,
Stool
exactly.
culture and sensitivity.
Yes,
And
exactly.
also we'll ask for fecal calprotectin, which is so important to differentiate between IBS and other inflammatory bowel conditions.
Yes, that's great. And also, don't remember the inflammatory markers such as ESR and C-reactive protein, which are also elevated in inflammatory bowel disease in comparison to IBS. And thyroid stimulating hormone, also to rule out any thyroid dysfunction affecting the bowel motility. Like you guys mentioned, stool study and stool culture for ova and parasite to rule out infectious causes. Fecal calprotectin, which is a crucial non-invasive marker to differentiate inflammatory bowel disease from IBS. Also, don't forget anti-tissue transglutaminase IgA and total IgA for celiac serology. So at this stage, based on the clinical picture, what's your working diagnosis? Does anyone have an idea? While waiting for her results. Yeah.
Can you please repeat this question in other words? I didn't get that.
What's the working diagnosis? Now we have to have like while waiting for the lab results, we have to have like what's the diagnosis for this case at this point?
IBS, irritable bowel syndrome.
Syndrome.
Yes. Exactly. But we need to rule out other organic causes because as we all know, IBS is a diagnosis of exclusion. So while waiting for her results, we could advise her on dietary modification and applying stress management technique, taking over-the-counter medication for her symptoms, and reassurance and education about the functional nature of IBS in other tests, if other tests comes back negative. And we should also emphasize the importance of a follow-up in every patient. We should emphasize the importance of that they should come back for the clinic, even if the initial diagnosis is somehow reassuring. So 2 weeks later, Sarah returns for follow-up. Her lab results are all unremarkable, aside from the fecal calprotectin, which came back positive. As you can see here, her lab result is 280, while the normal result should be less than 50. Now, given the elevated fecal calprotectin, how does our differential diagnosis now change? If you remember, we had a list of differentials at the beginning, and now we need to rule out some of them.
She has lactose intolerance
or inflammatory bowel, like Crohn's ulcerative.
Okay.
And so we have to do colonoscopy.
Yes. Okay, so this brings the inflammatory bowel disease to the top of the list, despite the initial lack of her classic red flags. Now, IBS is highly unlikely as the sole diagnosis, and other inflammatory conditions is less likely, but still possible. Infectious causes is now ruled out after the negative stool culture. So what does an elevated fecal calprotectin tells us?
inflammatory condition.
Yes, it indicates intestinal inflammation and is a strong predictor of an active inflammatory bowel disease. While it's not diagnostic of its own, on its own, it warrants further investigation. So our question here, what is the gold standard investigation to confirm or rule out inflammatory bowel disease?
Colonoscopy and biopsy.
Exactly, yes. Colonoscopy and ileoscopy and biopsies, because they allow direct visualization of the colon and terminal ileal mucosa and assess the inflammation, ulceration, and stricture. And we can also use it for collection of tissue for histopathology, whether to confirm the diagnosis and the type of inflammatory bowel disease, either Crohn's disease or ulcerative colitis. We can also consider upper GI endoscopy if there's upper GI symptoms, CT and MRI for small bowel assessment in suspected Crohn's cases. So Sarah underwent colonoscopy, and her report results are as follows. The gross findings demonstrate patchy inflammation with abscess ulcers, skip lesions, and coupled stoning noted in the terminal ileum and ascending colon while sparing the rectum. And the biopsy shows granulomas, transmural inflammation, and lymphoid aggregates consistent with Crohn's disease. Now, after the lab results and the colonoscopy report, she's now diagnosed with Crohn's disease. So let's go over the main component of inflammatory bowel disease treatment, which is a multidisciplinary approach essential for optimal care and improved quality of life. It involves inflammatory bowel disease specialist for ongoing management that includes both induction and maintenance therapy, registered dietitian for nutritional assessment and support, and psychological support to address anxiety, depression, or quality of life issues. In some cases, surgery is required when a disease leads to complications, such as fistula, abscess, and stricture. So we can stop here and ask ourselves, why was this initially challenging to diagnose?
Because it's atypical presentation.
Yes, exactly. Looking back
There
to the
were
patient
no
history.
red flags.
Yes, exactly. If you go back to the patient history, there were absent red flags at initial presentation, which made it less likely to be inflammatory bowel disease. And also the overlapping symptoms with irritable bowel syndrome, especially with her complaints, further clouded the picture. So this brings us to very important questions to consider. The first one is it appropriate to rely on presumptive diagnosis without a thorough investigation when symptoms may point to more serious conditions? So probably no, because while a working diagnosis is sometimes necessary, especially in resource-limited setting, it should not replace a full diagnostic process. Any case with alarm features or abnormal test, a further workup is crucial. Jumping to conclusion can delay the diagnosis and may lead to further complication, which would have been prevented, identified early on. So this is an important point we need to consider. And another thing is, when is it acceptable to limit or postpone diagnostic tests due to financial or patient-related factors?
It's difficult to depends on every case by case.
Yes, exactly. It's very difficult and unavoidable, but we must always be transparent with patient to avoid any ethical complications. And we have to tell the patient about the potential risk and ensure that the decisions are made collaboratively. And sometimes in cases where testing is essential to rule out serious illness, efforts should be made to find an alternative pathway, such as public funding, stage testing, or referral to higher level of care. Now, this graph here summarizes the differences between inflammatory bowel disease and irritable bowel syndrome, while also showing the similarities that may make the diagnosis more difficult sometimes, just like our case. As we can see here, they both are considered chronic disorder. They may have similar symptoms at presentation, such as abdominal pain, change in bowel habits, and the quality of life in both diseases are impaired. They're considered manageable, but still there's no cure for either of them. While in comparison, if you look into inflammatory bowel disease, it's considered an inflammation that's less common and can be life-threatening with complications. On the other hand, irritable bowel syndrome is considered a functional GI disorder that's more common
Nora, I think if you're still talking, the mic has a problem. Until Nora comes back, maybe we can, Nora, if you can hear us, can you check your mic? So in the meantime, if one of you have any questions, any comments and updates, we can talk about the last agenda in the items. In the agenda items.
Dr. Nadir, I have a question. Our team presentation will be next week, and to avoid the same problem happened now with Dr. Noura, I try to contact the team member to send me the presentation. So in case of the frozen screen or something happening to the presenter, I can work as a backup plan. So one of the member couldn't send me the presentation through email. Do you have any other application or suggestion that help them to send me the presentation?
Yes.
Hello?
Hello, Dr. Noura.
Sorry, I think something came up with something came with the.
We will continue with your presentation, but let me show them one way of for the interested speakers in the future. If you have any presentation that you have, let's say, slides, you can go to home, and then you can go to the upcoming, let's say, as you mentioned, next week, you will have some presenters. Let's say you want to write about grant writing, one of the speakers, Dr. Saida, for example. So if she has a presentation ready, she can hit here and go down and then upload the file. The first one usually it's taken, but she can upload the file to file number 2, file number 3, file number 4, etc. To help the moderator if there is any technical problems from the speaker computer or their aspects, mic and so forth. So we can move on. So either they can send the files to the moderator or the team leader and they can upload them, or the speakers themselves, they can upload the files and they can just refer to it if needed. Thank you. Dr. Noura,
thank you, Nadir.
Yes. So I'm not sure what slide were we when the screen stopped sharing.
Intersection between the two IBS and IBD.
Okay.
So the last part you talk about the common, and then the last 3 or 4 items. The first one, the functional versus inflammatory, and so on. So
okay, I'll continue from there. Yeah, sorry for the technical issue.
No worries.
Okay, so like I mentioned, the inflammatory bowel disease has red flag symptoms in the history of an examination, while in irritable bowel syndromes, there are no red flags. The treatment of irritable inflammatory bowel disease often includes immunosuppressive and anti-inflammatory medication, while in comparison to irritable bowel syndrome, the treatment often includes dietary modification, physical activity, coping skills development, but there are no pharmacological treatment for them. And lastly, lab testing and endoscopy are needed to rule out or confirm inflammatory bowel disease, while on the other hand, no labs, imaging, or endoscopy are needed for diagnosis of irritable bowel syndrome. However, those tests are still important and required to make, as we already mentioned that irritable bowel syndrome is diagnosis of exclusion. So we need to rule out all the other differential diagnoses before we say this is an irritable bowel syndrome. So to wrap up the presentation, this is the final slide. I want to leave you with 3 key takeaways from this case. First, we should always remain vigilant for red flag symptoms in patients complaining with the GI symptoms. Secondly, avoid dismissing symptoms as just irritable bowel syndrome without appropriate workup. And finally, misdiagnosis of inflammatory bowel disease as irritable bowel syndrome can delay appropriate management, which increases the risk of complications and worsening the long-term outcomes. So this is the end of my presentation. If anyone has any new information or any idea to share, please feel free.
Thank you so much, Dr. Noura.
Thank you.
Great presentation.
Thank you.
This is very good and interactive, and hopefully it will help you guys. Any comments, questions to Dr. Noura, or any other questions in general about the fellowship or ideas or?
I want to add about the fecal protectin. If it is negative, it does not exclude the inflammatory bowel disease. And if we have any other available investigation, we have to go with it.
Excellent. Thank you for adding that. Great presentation. And with this, we can end our meeting. I'd like to thank you all for attending this meeting. Thank you all for your participation and great activity. Thank you for the great presentation as well.
Thank you, Dr. Ali. And thank you everyone for participating and engaging in the meeting. Thank you.
Thank you, everyone. Thank you, Dr. Nadir.
You're welcome. If you have any question, please reach out. You can email or text or use WhatsApp or call me. I'll be happy to help you guys. And we'll see you next week. Assalamu alaikum.
Alaikum salam.
عليكم السلام ورحمة الله وبركاته. Thank you, Dr.
عليكم السلام ورحمة الله. شكرا لك دكتور نادر.